Welcome to the USCDI updates for versions 2 and 3. My name is Jennifer Gillison from Kaufman & Associates, and will be assisting with the logistical support for this Zoom session. At the bottom of your screen is a Zoom menu bar. Here you will find the Q&A box. We encourage you to use this feature to submit any questions at any point during the meeting. We will leave time for question and answer after the presentations. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speakers they present or share information. If you need technical assistance during the session, please type the issue into the Q&A box and one of our techs will respond to you. Please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. All phone and computer lines have been muted. I will now turn it over to Al Teller.
Thank you, Jennifer. It's a pleasure to be here today and to give all the attendees some additional information about USCDI, the different versions of USCDI, and we'll also talk a little bit about a related but separate program called USCDI Plus by our Office of Policy Representative Alex Baker. We're going to cover some core principles of USCDI. We're going to talk about what we colloquially call why USCDI matters, or the regulatory impact or the regulatory connections of USCDI. We're going to talk about the different versions and the process by which different USCDI versions are developed and published, along with the standards version advancement process, which is how USCDI becomes available to implementers and health IT developers for use in the healthcare setting. And then we'll also talk about the USCDI Plus program. As we mentioned, the three core principles of USCDI is that it's a core set of data, and that is a core set of data that can be expected to be available and shared between health IT systems, between providers, between organizations, and it's a reliable set that can be expected when a certain amount of healthcare data exchange is performed. It also establishes a consistent baseline, and that consistent baseline is important because there are a number of situations where the amount of information contained within USCDI is not always enough to meet whatever particular health data need. That data need can be identified by individuals, certain practices, or even by different programs, federal programs, and other programs that requires a certain amount of health data. And that information is not if that information exceeds what's in USCDI, we at least know that we at least know what's the core. So what is the baseline, and then what's the delta? What's the additional information that needs to be provided to meet that particular use case? USCDI also is intended to expand over time, and that expansion by new versions on the process. And we've been very clear on this since the beginning, since 2020, that this process is a predictable, transparent, and collaborative process. It's a public process driven entirely by the input by the public, and then ONC takes that public input and translates that into what the next new version or versions of USCDI is going to be. First version of USCDI, which is the one that was instantiated through the Cures Act final rule, which we published in May, I think it was May of last year, established an expansion of what used to be called the Common Clinical Data Set, and it involves this set of core data across the different data classes, and this defines the amount of information that certified health IT has to be able to capture, exchange, and make available to users of health IT. As I said, this was USCDI version 1 was initially published in the Cures Act final rule in 2020. The data set itself, USCDI is required for, in particular, for one new certification criteria, that being access to patient data through an application programming interface. That is a new API criteria that uses the FHIR US Core implementation guide to define what can be exchanged using FHIR. In addition to serving a new certification criteria, USCDI also replaces the Common Clinical Data Set, which is that other core information set of health data that was required for certification under the 2015 certification rule. The criteria that use USCDI that previously used the Common Clinical Data Set are also exchange criteria. And those exchange criteria are listed here, and they use the exchange standard that uses the Common Clinical Data Set and now uses USCDI version 1, are using both the consolidated clinical data architecture standard as well as the FHIR US Core standard. The last of these, access to data via API, is the one of these that used to call out Common Clinical Data Set and now calls out USCDI version 1. USCDI also defines what's considered to be electronic health information, and that is the definition used under the another provision of the Cures Act, which is the information blocking provisions. And I mentioned that USCDI defines EHI for the information blocking purposes for now, and we'll talk about that as far as the timeline goes. So here's a couple of key dates that were put out in the final rule that implemented both information blocking and the new certification criteria. The first one is April 5th of last year. On that date, quite a few things happened. Well, number one, USCDI became available for updates to Health IT, meaning that Health IT developers could begin updating their systems and providing those updates that include USCDI version 1 to their customers. And so the USCDI criteria and the other Cures Act criteria were now available for certification as of April of last year. Another thing that happened on April 5th of last year was that the information blocking provisions kicked in, which means which said that information sharing, the norm, and information blocking would be subject to some civil penalties. Not going to get into a lot of details about information blocking, other than to say that the amount of information that's considered to be the amount of information that, if not shared, is considered to be the data that's defined by USCDI, and that's the term that's currently called electronic health information. That is the definition. The electronic health information is the amount of data that is subject to information blocking provisions. Now through October of this year. After October of this year, the information blocking provisions call for all electronic health information that is managed by a health IT system. And it's not only the information that's in USCDI, it is the information that's included in USCDI, but that's not all is covered by information blocking. And then the other key date all from this year is that at the end of this year, December 31st, all of the Cures Act criteria must be made available to customers, and that includes the mandatory implementation of USCDI for certified health IT. Talk about the expansion process. How do we get from version 1 to the next versions? We started, like I said, it was a public process, and that public process really is foundation. The foundation of the public input process is our new data element and data class submission system called OnDeck. Registered users of any sort, from any part of the health IT landscape can submit for additional data elements that expands on USCDI version 1. ONC evaluates those for a number of different criteria, including overall value, data maturity, maturity within the particular standards, along with any challenges that might be in place for implementation, be it licensing fees or difficulties in developing standards to support a new data element, or any number of different reasons why it may be difficult. And so we evaluate those and assign them a certain level, and level 2 is the good one. That's the one that shows that it's most mature and most capable of being implemented if we were to add it to USCDI. And then ONC evaluates those criteria and lists them all, and we currently list all of the submitted data elements by maturity or by level on the USCDI website. We take all of the submissions and based on all of those submissions and that were put in before the cutoff date at the end of September, those will be considered for the most mature of those will be considered for the next version of USCDI. We publish a draft version of whatever version we're working on at the time in January. We did it January of 2021. And we just did it, we'll talk about version 3 in a minute, but we just did it for the draft USCDI version 3. Once we do publish that, then the draft is then evaluated by the public again. What we put into USCDI or a draft version of USCDI is then put out into the public realm for evaluation. Our Health IT Advisory Committee also looks at it and gives us formal recommendations about what ought to be included, maybe what ought to be taken out, and what ought to be changed in that particular draft version. And then in July of each year, now we're hoping for the second year in a row, we'll publish a final version of USCDI version 3 based on all of that input that we get over the next couple of months. We did that last year. We did publish USCDI draft V2 in January, and then in July of last year, we published the final version of USCDI version 2, also available on the USCDI website.
Al, this is Carmela. We had a question in the chat.
Sure.
Are there plans to have a yearly revision where the request for the new data elements are collected?
Yes, that is our plan. Yes, straight up. Yes, there are. That's our current plan, and that's actually our current pace right now. We're doing annual. We're now on our second annual update cycle, having just published draft V3. I mentioned the on-deck system. The on-deck system is available to anybody, and a lot of folks took advantage of it last year. We got over 600 submissions, all of which we evaluated individually, determined which of those were the most mature and most ready for consideration for addition to USCDI. Obviously, an expansion of USCDI that increases it by 5-fold or 10-fold is simply not a feasible update. We had to pick amongst those that are most mature and most broadly applicable to the most number of users. And we use these prioritization criteria to select amongst those most mature data elements for addition to USCDI. And the gist of these criteria are they need to be ready to be implemented. If they require a lot of development, standards development, it's very difficult to implement into EHRs, whether it's difficult to implement into the EHRs themselves or the workflow that uses the EHRs, that would be make it much more difficult. And so we selected amongst the ones that seemed to be the most ready. And that was some of the feedback that we got when we published the draft last year and hope to get this year are these, not only are they mature, we think that these are mature, but are they feasible to be implemented into EHRs? Based on that prioritization criteria, like I said, we got over 600 individual submissions. We had over 100 of them that we consider to be the most mature, or this level 2 that we talked about. And amongst the level 2, we picked 22 new data elements in for USCDI version 2, which was published in July of last year. It included additional data elements in a number of different data classes, but it also introduced 3 new data classes with clinical tests, diagnostic imaging, and encounter information. One of we highlighted 2 particular data sets of data elements that we added to USCDI because of a new focus with the new administration on this issue of health equity, and our national coordinator Nikki Tripathi talks about equity by design. So by starting knowing that we want to build something that explicitly supports health equity, what are some things that were submitted in the ONDEC system that would do that? And we added 2 sets, I guess you will, of data elements. One is sexual orientation and gender identity, the 2 patient demographics data elements, and the other is 4 data elements associated with social determinants of health. We feel like that was a good start in addressing health equity, recognizing the importance of both of these groups of data in that area. Like I said, sexual orientation and gender identity, one thing to remember is that the ONC certification criteria dating back to 2015 already required that EHRs were required to be able to collect data using a set of standard terminologies, both for sexual orientation and gender identity. At that time, we did not feel like it was ready, that set of data was ready to be exchanged using the required exchange criteria. And therefore, we didn't include it in what was called the Common Clinical Data Set at the time. Systems had to be able to capture these data elements, but they were not at the time required to exchange them using those exchange criteria. Putting it in the USCDI version 2, should version 2 become available for updates, then systems would be required to exchange sexual orientation and gender identity like other demographic data elements, with following a fulfillment of the request for exchange of information. Social determinants of health is the other group. We recognize the value of social determinants of health data, which actually represent a subset of different data classes or different data elements within USCDI version 1, and those different data elements that were assessment, goals, interventions, or procedures, along with problems or health concerns. And USCDI version 1 already had these data elements, or some version of these data elements, but recognizing the importance of focusing on SDOH issues, we felt like it was important to require that the SDOH data elements, or that this version of USCDI included these data elements, so that systems would be able to collect not just assessment data, but also specifically SDOH assessment data, so that information could be understood, semantically interoperable between systems, along with being able to measure the evaluation of SDOH in the clinical settings. We published the final version of USCDI version 2 in July of last year. In the standards bulletin, which is our standards division, which is a branch of which is part of our Office of Technology. We published the standards bulletin is a way that the standards division can communicate a number of different standards initiatives. We have a number of standards initiatives at ONC, obviously, but we highlight these in the standards bulletin, which we are currently publishing about quarterly. And within, not only do we discuss, present, and explain some of the rationale for including what we included in final V2, we also identified some additional prioritization criteria as we got ready for the USCDI version 3 submission process. And so began the USCDI version 3 submission process. In addition to the existing prioritization criteria that I discussed earlier, and keeping in line with the focus on health equity and public health, we stated upfront before the submissions came in that ONC would be giving at least some priority to submissions and data elements and data classes that address these specific concerns of health equity and disparities, the needs of the underserved individuals or stakeholders, along with addressing public health interoperability needs, particularly in light of the pandemic, which has been, ripping our country and the world for now 2 years. And so recognizing the importance of being able to share more public health information, those were the prioritization criteria that we further considered for addition. So amongst the 150 or so data elements that came in that were most mature and most broadly applicable, we gave some priority to these areas. And this is what the current draft version of USCDI version 3 looks like. A couple of things to note. We added 2 new data classes, health insurance information and health status. Both of those have data elements within it that address a number of different equity disparities and represent members of the community that are generally considered underserved. Health insurance coverage and status, along with the health status, which health status is a new data class, but it really is a merging of an old data class called health concerns and the smoking status data class into one data class called health status. I'll talk about that in a minute as I talk about the other some highlights of the changes in USCDI version 3, the draft V3. And we also added a number of different patient demographic data elements to assist in matching and also to identify areas of disparities. And again, the new data elements under the patient demographics data elements are listed here, and I'll just go through them each data class at a time to highlight these 3 data classes that had a lot of changes. So we talked about health insurance information, the data elements around coverage, but also the data elements that are some version of an identifier for a patient or a payer that help with patient matching, but also support some of the payers' data requirements for within health IT.
Al?
Yeah.
Would you go back to health information, please? We have a question in the chat. So the description of the new coverage status element in the health insurance information data class indicates that it's specific to a particular encounter or claim, but there's no element which captures the relationship via a reference or a link or an identifier to that encounter or claim. Furthermore, this is the first requirement for claims, and claims themselves are not currently included in the required USCDI V3 or proposed in the USCDI V3. Are folks supposed to exchange claims associated with included coverage status data, or are we supposed to have broken references or missing related data?
The data, thanks, Carmela. The coverage status, understanding that the coverage status is associated with a particular claim or particular encounter. But we did not add claims data. We have encounter data. We did not add claims data to the draft USCDI V3. And we did that because we felt like the status itself, rather than the association with a particular claim, is its own valuable piece of data. And it identifies a group of patients, especially the absence of coverage, identifies a group of patients that may require additional either assistance or additional focus to ensure that their care is provided in an equitable manner. For the data elements that were not added to USCDI, I'm going to get to that in sort of the ask of ONC while we publish the draft version. There are any number of different data elements that were not added to USCDI that we certainly could consider adding, even though they didn't make it into the draft. And so depending on what the, the sort of explanation or the rationale for considering addition of a particular data element, like a claim of individual claims data elements, ONC will fully consider that recommendation as we prepare the final version of USCDI in the late spring and summer. The health status is a new data class. Like I said, it merges the health concern data class. It actually merges another status data class, the smoking status, and it adds a number of different data elements, very interrelated data elements, but we felt like they were different enough and warranted individual attention to the different categories of status or function that they warranted separate data elements. Just like the SDOH assessment we felt like it was important to single that out as a unique assessment data element. We felt like these data elements around status and function were also valuable to be singled out. That said, we have already started to get feedback on whether or not maybe these should be combined or they should be separated. But there is rationale for each of these data elements. We felt like that those rationale were sufficient to separate them out into different ones. So the disability and functional status, obviously very related. Another way to think about it is two sides of the same coin, if you will. Pregnancy status has implications both in a variety of different pandemic responses. We have been struggling with pregnancy status, how to capture it, how to represent it, going back as far as the Zika pandemic as well. And we felt like it was ready enough to add to the next version of USCDI. And by adding health concern and smoking status to the health status data class, we actually were able to, the draft V3 actually gets rid of two data classes, which is really just an organization around a common theme. And we felt like the common theme of status or function was sufficient to include these in this particular data class. We also added 6 new data elements in the patient demographic. They include date of death and tribal affiliation. We also added the concept of related person, and this is a related person who's part of the care. This is different than care team member, which could include a family member, but the family member who's more of a caretaker is the family member that would be considered part of the care team. The related person could be any relationship with the patient, somehow involved with the care, obviously not the target of the care, that's the patient, but to identify both the person's name and the person's relationship to the patient. And some examples here: emergency contact, next of kin, are some examples of what a related person could be. The occupation and occupation industry are 2 data elements that are represented by a new data model called the occupational data for health. This is a data model that was developed by by NIOSH, part of CDC, and they have been working on being able to represent in a very logical way a person's job, their work, the type of industry that they're in, as well as their military status or veteran status. This data model was built to represent all of those things. There's a lot of different data elements that are part of the occupational data for health data model. We included these 2, which are around either the immediate or past job, the current work, but there are a number of different data elements that were also submitted for this under this submission, and those also could be considered for addition to these 2 for inclusion in the USCDI version 3. And keeping with our tradition, we published the standards bulletin in January of this year. And again, would encourage everybody to review our standards bulletins. They do a really good job of conveying information that's important to us, at the time of this release, and obviously publication of draft version 3 or the final version 2 were really key milestones in ONC's development of standards. And so we highlighted it in January of this year, not only giving additional details on rationale for the things that we did add, but also a call to the public to give us more feedback on what we did publish. These are a few questions, and this is lifted directly out of the standards bulletin, so don't try and catch it all now. But if you go to the standards bulletin and look for the feedback towards the end of the standards bulletin, you'll see some specific questions that we're asking. The first set were questions that we asked last year for draft V2, but we also realized that there were some existing data elements. These are part of these are data elements that were part of USCDI version 1 and version 2, and we felt like the climate was such that it warranted another look. Do we have the right value sets? Do we have the right vocabulary standards? Do we have the right data element definitions for these 3 data elements: the sex assigned at birth, gender identity, and current and previous address? Actually 4 data elements. Do we have things right? Should we make changes? Should those changes align with some new and evolving standards that we have just started seeing come online? The Gender Harmony Project, for those who aren't familiar with it, is developing standards for capture and exchange of various sex and gender concepts, and they have one that because it was developed for maybe a slightly different use case than what ONC certification program developed. The definitions and the terms and the value sets that represent these 2, sex assigned at birth and gender identity, are a little bit different than ONC. And so the question that we have out to the public, to our advisory committee, is does what ONC have for these 2 data elements, is that still right, or should it evolve into something different, or should it evolve into alignment with the Gender Harmony Project definitions? We recently announced the availability of the first version of the specification, what's called Unified Specification for Address in Healthcare. Short name is USA. And that is a new standard for standardized patient address in healthcare, and it evolved from the U.S. Postal Service standard, but it is specifically designed to capture address for healthcare. That can be for business purposes, so mailing, billing, and the like, but it can also be used as a patient identifier as well, both current and previous address. And so those are the questions that we have out to the general public on these particular 3 existing data elements, plus the ones the new data elements that we put into the draft USCDI version 3. So we've talked about a lot of the versions. So version 2 last year, version 3 this year, and then so what happens with these versions? We are doing this process. We are developing new versions of USCDI as the data requirements and the data maturity increases. What our vision is that these updates to the data set be incorporated into health IT. Short of the entire rulemaking process that we go through every few years, we can't require that health IT or implementers or providers adopt these updates to USCDI or any of the other standards that are part of the certification program. So what we developed is the Standards Version Advancement Process. The Standards Version Advancement Process, or SVAP for short, allows health IT developers of, again, certified health IT to voluntarily update their products. to these new versions. And one of the standards that has a new version is USCDI. There are other standards. There's quite a few other standards. When we put our first version of the approved standards list out in 2020, we incorporated just a couple. These were standards that were new over the last 10 years. And they represented a significant advance in the standards, and so they were incorporated. Now, systems can voluntarily update to modern web user interface standards, quality measure reporting standards, and some others. We anticipated that this be an annual process. Because once we published USCDI version 2, I'm going to talk about that in just a second. We expected to be an annual process, but we didn't get one out in 2021 because of version 2 and what's required to incorporate version 2 into Health IT. So like I said, the USCDI version 2, which was published last year, will be considered for the approved standard. So that's the next version of SFAP. But as I mentioned at the beginning, USCDI by itself can't really be implemented into systems. They can be implemented only to the extent that systems can capture those data elements. In order to exchange those data elements, those new data elements, new versions of the standards for the Fire US Core and the CCDA implementation guides, those are the exchange standards that move at USCDI data. Those standards needed to be updated as well. It takes time to adopt a new standard, to make changes. And there's a continuous cycle in the fire community and the whole HL7 community to update standards. And that process takes time. As soon as USCDI version 2 was published, HL7 got started on making updates. And for those who are familiar with the update process, it's not easy and it's not quick. And so the community has been working diligently on updating those standards to reflect the new data elements in USCDI version 2. We expect those updates to happen early this year and be going through ballots very soon and then published in the spring. Once they're published, those two standards are published, those three standards together, USCDI v2, the HL7 Fire US Core and CCD implementation guides are the other two new standards. They can all be considered for addition to SFAP to the approved standards list. Should they all be included, Health IT developers can then use those standards to update their systems to not only capture USCDI data, but also to move it, to exchange it and with patients, providers, and other systems. This is a super busy slide, and I just wanted to. I wanted to give an overview of the rhythm of the process. We are currently in the. So we just published USCDI version, the draft V3, and so we're now in this period where our Health IT Advisory Committee and the general public is invited to comment on what's included in the draft. That input period goes through the end of April, and once that comment period or feedback period has ended, ONC will then take all of those comments and figure out what amongst the draft USCDI v3 data elements or any of the other data elements that were previously submitted, which of those ought to be included, and then publish the final version of final version of USCDI version 3. Once that's finalized and the standards to exchange USCDI v3 are updated, those are the US Core and the CCDA, then they will all three again be considered for the standards version advancement process in the following year. And that is all I had for USCDI. Carmela, do you have any questions right now?
I do have a couple of them. There's a lot of questions around when we think version 2 will be required in certified health IT, or version 2, okay, version 3. So there's a lot of variations on that.
Okay, So the USCDI version, so version 2 of USCDI, first of all, it's none of the SFAP requirement, none of the standards that go through this SFAP process will be required. They will only be required for updates when ONC puts out a new certification rule, and that goes through the entire rulemaking process, public comment, feedback, and so USCDI version 2 will not be required until a new rule comes out, or perhaps a future version of USCDI will not be required. What we hope to happen later actually in the spring or some early summer is that USCDI version 2 and those supporting exchange standards are added to the approved standards list. Once those are available, we expect that if those are added to the approved standards list, they become available for health IT developers to update their systems voluntarily starting in about August of this year. There's a lag between when it's on the list and when it becomes available. But once it's available, then starting in around August of this year, we hope that those standards become available and systems voluntarily update their health IT developers voluntarily update their systems, provide those updates for version 2 to their customers. The same thing would happen with version 3. Hopefully would be added to the SFAP approved standards list for 2023, and then be made available for voluntary update to version 3. As far as requirements go, like I said, none of these will be required until we propose that requirement in a proposed rule. We have no timeline right now for when that might happen, but we would like to see these things be updated voluntarily, and so that the advancements that USCDI V2 and then V3 offer healthcare in general would become available again, but we can't require it.
So we have a question about the on-deck system to submit, so for submissions to USCDI. And there are some questions about whether that's the same system that would be used when submitting things for ISA.
Yeah, thanks. No, it's not going to replace the workflow for ISA. So USCDI is a little different. It's different than the ISA. The ISA is a platform that we have. I like to think of it as a compendium of available standards. Again, available standards. Some of those standards are required by our certification program or by some other federal agency. They could be for public health reporting or anything else. But they could also just be maybe notional, is a good word. These are standards that are recognized, maybe recognized as being, in widespread use or widespread consideration, but not necessarily proposing that they be part of USCDI. And the standards that are part of the ISA go way beyond just the terminology standards that USCDI covers. They include process standards like, exchange standards, security standards, privacy standards, consent standards. These are things that are well outside the realm of USCDI right now, but the ISA is able to capture. So anyone can go in and recommend that is at least recognized that this is a standard for a particular purpose, whether it's got anything to do with USCDI or not. The on-deck system is specifically designed to accept submissions from the public on potential new data elements in USCDI. We continue to plan on keeping them separate. This comment process for the ISA and the submission process for USCDI, we plan on keep separate.
Al, we've had a couple of questions about the criteria that ONC uses to evaluate submissions. Is that publicly available?
It is. Hang on a second. Let me go back to it real quick. Where did it go? Oh, yes. This is in addition to the criteria that we mentioned for V1, V2, we publish these additional prioritization criteria. This is published. These additional criteria are published in the July 2021 Standards Bulletin, also known as the third edition of the 2021 Standards Bulletin.
Thank you. So we have a couple of really specific questions about some of the data elements. Are you ready for a couple of those?
Sure.
Okay. What can you tell us more about family member history, health history?
Well, so family health history is a data element that is part of part of certification. It's not family health history. It's not part of USCDI, but it is family health history is a particular aspect of certification. The new data elements that were proposed for draft V3, the related person name and relationship, could actually go a long way toward helping. That can be used to represent family health history, at least the person part, not the history part, but the person part, to help identify which family member this history is related to.
Okay, thank you. There's a question about HL7 version 2. Are there any certification timelines defined related to that? So your presentation mentioned US Core, Fire US Core, and CCDA. Would implementation still be compliant if they manage these elements using HL7 version 2?
So the criteria, there are criteria, and I have to beg forgiveness. I can't speak on the particular certification criteria that invoke V2 messaging, but I know that there are some, and the requirements, the data element requirements for V2 are different than the data element requirements for US Core or for CCDA. So it does not specifically, those criteria that use V2, the certification criteria that use V2, do not specifically say data elements within USCDI. And prospectively, I don't have any information on what might change.
Okay. Thank you. A couple of people have asked about the patient demographics data class. There's some general comments about, I'll just tell you, some folks feel that it's beyond demographics, some of the elements that are listed. And another related question is, are all of the demographics data elements considered EHI and would need to be included in a designated record set?
As it stands right now, the content of not this set of data elements, but what's in V1, those data elements are part of what's defined as EHI, yes. To the comment about demographics, the patient demographics data class going beyond demographics data, it's a good point. And what we would really like is for that comment, particularly a suggested change, to go into the patient demographics USCDI website, as we collect a lot of different. I know we've already gotten one comment entered there on the demographics website, the patient demographics website on USCDI, to change the name of demographics, whether it's I can't remember what the suggested name, other than to change it from demographics, because things like related person's name is not really a patient demographic. It's a way of connecting patient information. So any suggestions about maybe a better name now that this category, this data class is expanding, would be welcomed, and welcomed before April 30th, please. Can someone from ONC put the website for the draft V3 tab up, please, in the chat, or we have chat can go to everybody, right? Thank you.
There have been a couple questions about naming conventions. Here's one about USCDI and ISA, interoperability standards advisory, not using the same terms for the same things. And then another one is related to, some of the data elements that we list are might be considered atomic, but others are pretty complex data elements. Like, for example, an SDOH assessment is not just a single data element. Can you speak to that?
Yeah, well, I think that, so I agree. So different data elements may have some level of complexity. A really simple one is address. So address could be considered like the entire address, which is, street name, street number, city, state, zip, country, or it could just be address, with the expectation that it contain at least a minimum set of information. That's a not terribly complex one, but it's a little bit complex. So with the SDOH assessment data element, and this is why we put it into the assessment data class, assessment and plan of treatment data class. So when we refer to a data element, we're not talking about a particular term or a particular SDOH assessment instrument. We're talking about the concept of an assessment for an SDOH problem or an SDOH concern. And in that way, the SDOH assessment defines related structured assessment instruments that carry with it a particular code. So there is a particular code that defines the entire PRAPARE, P-R-A-P-A-R-E, assessment instrument, which is widely used in community health centers and other places. But that's one assessment instrument. There's other ones like a hunger vital sign, transportation insecurity assessment, food insecurity assessment. Those are all SDOH assessments. They all have their own LOINC code, but there's many members of that data element. There's member terms of that data element, but it is considered a pretty consistently defined data element of SDOH.
Thank you. So a couple questions. If you could just repeat, clarify the relationship between certification and USCDI version 1. Remember that
Sure.
timeline slide you had?
Yeah. So I can let me just talk through it. It took me a minute to flip back up to it. So the Cures Act was made available. The Cures Act introduced new certification criteria. It's called the Cures Update to the 2015 certification edition. The Cures Act introduced the new certification criteria. There was an implementation timeline for that. It's a required implementation timeline for certified health IT. The certified health IT that want to stay certified with ONC has to be updated. They have to be certified by the end of this year. And so that's USCDI version 1. That was the version that was required in the last rule that we published. And that is the one that is required to be updated to maintain certification before the end of this year. By the end of this year.
And how are we doing on time? Should we end here and move on to Alex?
I think we probably should. I wanted to just in summary, first of all, thanks for the questions, the comments. A lot of these concerns are exactly what we're looking for as we publish draft V3. And we're not looking just for comments on the 20 new data elements that we added and the 2 data elements that we moved and the 2 new data classes. We're looking for input not only on that, but we're also looking on, like we went over some specific concerns. I want to encourage everybody to review what we published, review the standards bulletin, answer the questions if you want to. If you feel like you have an opinion on it, with whatever supporting information you can provide to justify the recommendation. We really are looking for feedback from the public, all of it, and so that we can make sure that we get it right when we publish V3 in the fall. And so if we go to, and I'll make sure that it's in the chat. I can't see it right now, but we'll make sure it's in the chat where you can go and review and submit your comments. And we really encourage everybody. We'll look forward to seeing what everybody has to say. I will turn it over now to Alex, I'm gonna flip slides for him. And let me see, hang on a second, let me find your slides. And yeah, I'll start there, Alex.
Great, thanks, Al. So again, my name is Alex Baker. I'm in the Regulatory and Policy Affairs Division in the Office of Policy at ONC, and wanted to just spend a couple of minutes at the end of this presentation talking about USCDI Plus, which is a concept that a lot of folks may have heard of now after a couple of months since it came out, and just kind of reviewing sort of the rationale for this and ONC's goals for this, and just a little bit of where we are and what is to come. So just to sort of recap on kind of where the USCDI Plus concept came from, since ONC introduced USCDI and since it created the framework around USCDI, have just seen this incredibly enthusiastic response and sort of interest in having this transparent process around a core data set for interoperability. Have received tons of ideas for what should be in USCDI, including a lot of input from our federal partners. And this, I think, really shone a light for ONC on the current state where we are sort of going forward with USCDI, but so many of our federal partners have very specific data needs for their own constituents, for the specific areas of healthcare that they work on. And right now, those data sets may go far beyond what is in USCDI today, or what is on the near term, things that might be on the roadmap. And so, agencies are really pursuing these data needs so they can meet their own needs in an ad hoc manner. And that really creates some potential problems where different data sets are getting farther away from USCDI, presents issues around life cycle maintenance and how we update these things, and potentially makes it more difficult for industry and other stakeholders who can benefit from greater alignment across data sets that may be attached to requirements from all of these different federal agencies and programs. So next slide. Oh, you go one more. Oh, slow dissolve. So kind of looking at that landscape, ONC saw that the solution was not necessarily to be able to put all of this in USCDI, because that would create a lot of potential challenges around growth in USCDI, which is growing incrementally and which needs to grow in a fashion that doesn't create excessive impact on certified EHRs and the certification program. So the concept that came out of this was USCDI Plus, and we announced this back in October in a blog post on the website, which folks can go look up. And that announcement talked about USCDI Plus as a service that ONC provides to federal partners who have a need to establish, harmonize, and advance the use of interoperable data sets that extend beyond the core data in the USCDI in order to meet agency-specific programmatic requirements. And we really see this as a way to better serve federal partners that do have very critical data needs for around their own programs and around the important healthcare goals that they support. And this also ensures that as folks are building out other data sets, we can align those with the core USCDI foundation and create better opportunities to align across what other agencies may need and what we do at ONC with certification with the core USCDI. And that blog post also talked about the two initial partners that we have been working with on this concept. So around quality measurement, have been working with CMS, and if folks have been following some of their rulemaking, can see a little bit of what CMS has been contemplating about the future of quality measurement in their programs and how to improve the technical underpinnings of their quality measurement programs. And then we've also been working with the CDC and really looking at all the data that is needed for public health partners around the country that goes beyond what we have in the core USCDI. So next slide. So just for maybe a little bit of flavor of how we are starting to think about this service, this program is obviously still new, and we're in the process of working with those other federal partners to define how this will work and define how it will move forward. As we work with each federal partner, have been really engaging in this process to determine sort of their own commitment of stakeholders, understanding demand around this, understanding, really trying to define a use case or multiple use cases so we can better understand the data that needs to meet their needs. Thinking about how USCDI Plus could be implemented for agency stakeholders. So thinking about the different policy levers that federal partners may have with stakeholders to sort of drive better harmonization and alignment in the data that they're using. Goes along with that to sort of understand the regulatory and programmatic levers that those federal partners may have. And then understanding the resources that will be required to make all of this work. And really on the right here is kind of a sense of the goals that we are trying to get to as part of each of these engagements with federal partners that are really looking to leverage this service. So driving towards nationally recognized data sets that can advance program goals and interoperability, defining ongoing maintenance and stewardship of those data sets so that there is evolution as there is with USCDI Plus, or as with core USCDI, defining those repeatable processes for creating robust data sets beyond the USCDI. And really, we are looking at a lot of the processes that have been established for USCDI now, and looking at sort of similar ways that similar processes that can be used to evolve these USCDI Plus data sets and activities. Then looking at harmonization, as that is a key goal of this program across the different use cases to reduce fragmentation and data silos, and harmonization across these different data sets, different USCDI Plus that would emerge as part of different USCDI Plus domains, so that we can really get to that ultimate goal of optimizing investments in interoperability for industry and other stakeholders. So hopefully that gives folks just a little bit more of a recap about what we are thinking about with USCDI Plus, and will definitely be more to come as we get deeper into this concept, and open to respond to any questions.
So we have a couple of questions really about the relationship of USCDI Plus to USCDI. Can you explain, just as USCDI Plus at some point be folded into USCDI? Are they considered to be separate data sets for each one of the use cases, or how do we see that working?
Yeah, no, that is a great question. Definitely one of the key things to understand here. So these are separate, and we're developing the data sets, the USCDI Plus data sets, sort of to meet the specific use cases of these agencies. Obviously, will want to build on the same data that is making its way through the USCDI process. Data that is sort of identified as part of these USCDI plus domains could also be considered for inclusion, and I think there'll probably be some back and forth there as other mature data elements in USCDI plus domains are sort of come forward and could also be submitted to USCDI and go through the the regular USCDI process, but there's not sort of a clear on-ramp from that all USCDI plus data will eventually be folded into USCDI.
Thank you. Is there any opportunity for public comment yet about USCDI plus and about the plans, or is that not yet in place?
Yeah, that is what we certainly welcome, any feedback on the concepts that have been presented so far, but have not, presented anything sort of formal enough for comment. I think as these engagements develop with different federal partners, hoping there'll be more about that in the future as we, those data sets become public.
And back to quality measures, can you explain a little bit about your thoughts about USCDI and support of quality measures?
So I think what CMS has been looking at is how to identify the data that they need for quality measurement and how they could, directly obtain data from EHRs and do the quality measurement that they need to do in a way that doesn't, sort of necessarily require all the infrastructure around EHR, each system having to calculate all that quality measurement. If folks take a look at the extensive RFI that they put out last year in the hospital rule and the physician fee schedule, they provide a little bit more detail about where they're thinking of going there. And so our work as part of USCDI Plus is sort of looking at, the certification program and what is in certified EHRs and how we would potentially move forward together to leverage the standards that are available to support that quality measurement vision.
Okay, thank you. This one I hope will be pretty straightforward. Will there be an on-deck process for USCDI Plus for submissions as well?
So USCDI Plus wouldn't use the regular on-deck process that USCDI is using. I think we're looking at a similar kind of framework that to gather comments about those, but that will probably develop sort of with each of the federal partners and sort of with each of those engagements.
Do you envision something similar though to on deck?
Yeah, I think there will definitely be some kind of infrastructure in which we'll need to be able to get comments back on those at some point.
Great, thanks. Yeah, some of these might be things that we just don't know yet since it's so early. Do we anticipate that USCDI Plus might have a similar cadence to USCDI, a regular release cycle?
Yeah, the goal is definitely to have a regular release cycle. I don't know if I think it's early to say whether that would be sort of the annual basis that USCDI has established, but definitely a core goal of this is to have these data sets that meet other partner needs, be able to evolve at a sort of standard pace and, as other data elements become mature and as we're better able to expand them.
Mm-hmm. Well, I think I've covered all of the questions in the Q&A that are specific to USCDI plus. If not specifically, at least in a general way.
Okay, great. And you know, again, more to come on this, and we can put up contact information at the end. And if you know there are specific questions about USCDI plus, please don't hesitate to reach out to us, and we'll do our best to answer with what we know now.
Should we advance to the contact information slide?
Yep, let's do that. Oh, Al, do you have any final things you want to say to wrap us up?
I wanted to thank everybody. There's a ton of questions. We're working on trying to get the best answer for you on them, and we will try and follow up with all of the questions. But I wanted to thank everybody. A lot of great questions, and some of them pointing things that we can do better to provide more information for everybody. Continue to get the comments in again now through April, the end of April, through the USCDI website, and because we will take a look at everything that gets submitted for USCDI version 3. So please tell all your friends, get the submissions in, or get the comments in by April 30th for this go round. And that's all I had. Anyone else, Carmela, Orion, have anything else that want to mention?
No, I'm all set.
No, thanks everyone for your great questions. We'll look forward to talking again soon.
Thanks.